This is Elena Coucher. I'm going to be doing part 2 of applying theoretical knowledge and skills of pharmacology with neurologic and neuromuscular agents to patients with chronic, acute, critical, and mental health care needs. So we're going to talk about Parkinsonism first. It is an imbalance of neurotransmitters, dopamine and acetylcholine. Dopamine is an inhibitory neurotransmitter and acetylcholine is an excitatory neurotransmitter. Dopamine usually maintains control of acetylcholine and inhibits excitatory response from it. But with Parkinson's disease, there happens to be an unexplained degeneration of dopaminergic neurons and an imbalance between the dopamine and acetylcholine occurs. With less dopamine production, acetylcholine becomes unopposed. It causes excitation and stimulation of neurons that release gamma aminobutyric acid, or GABA. With increased stimulation of GABA, symptomatic movement disorders then begin to occur. Characteristically, these patients present with tremors of the head and neck, rigidity, bradykinesia, postural changes. The head and chest are thrown forward, shuffling walk, lack of facial expression, and a pill rolling motion of the hands. So what do we do for it? We usually prescribe anticholinergics for these patients. They reduce the rigidity and some of the tremors that are characteristically displayed by Parkinson patients. However, they do not help with bradykinesia. On the next slide, we'll look at some of those different meds. Benadryl, it's interesting to know, is actually being an antihistamine, but it does have some anticholinergic properties. So there are times it is used in the older adult to treat mild symptoms of Parkinson's. Dopaminergics decrease symptoms of Parkinsonism. The drug of choice for many years was levodopa, but it is no longer used because it is metabolized very, very quickly, and it's coupled with some massive side effects. It's a better alternative drug that is used now is carbidopa. MAOBs are monoamine oxidase B inhibitors, and these catabolize dopamine, and COMT are catch-all O-methyltransferase, which inactivates dopamine. Anticholinergics are parasympatholytics that inhibit the release of acetylcholine. They're said to treat drug-induced Parkinsonism as well, or pseudo-Parkinsonism. Cogentin may be taken with other anti-Parkinson drugs. It is contraindicated in patients who have glaucoma, GI obstruction, severe ulcerative colitis, prostatic hypertrophy, and myasthenia gravis. Biparidine, with prolonged use of this med, the patient may develop a drug tolerance, similar contraindications as cogentin. In fact, many of the neurologic drugs do have some of the same contraindications. However, avoid taking with alcohol or CNS depressants. Patients may develop a dry mouth, blurred vision, drowsiness, muscle weakness, and constipation. And finally, Artane. It does not treat drug-induced tardive dyskinesia, but it is used for treating involuntary movement symptoms. What do we need to look at? We need to look at some nursing interventions, because these are the things we're going to need to focus in on for our patient. Knowing the signs and symptoms of their diseases, knowing that what drugs help with, what we can expect their medical treatment to be, but also knowing the signs and symptoms of side effects. Nursing interventions for the anticholinergics. We're going to monitor the patient's vital signs. We want to monitor their urine output for early detection of urinary retention. Increase their fluid intake, encourage increased fiber, exercise to avoid constipation. We want to observe for involuntary movements, because the goal would be that when we start these drugs, that these involuntary movements would be decreased or even cut out completely. We want to advise our patients to avoid alcohol, cigarettes, caffeine, and aspirin to decrease gastric acidity. Encourage the patient to relieve dry mouth with ice chips, hard candy, or sugarless chewing gum. and this suggests the use of sunglasses for the photophobia that occurs with the medications. So let's assess what we're going to do. Let's look at our nursing process for an anticholinergic agent with a patient with Parkinson's. So what would we assess? How would we assess? We want to get a patient health history. Very important. Pay attention to the history of glaucoma, any GI dysfunction, urinary retention, angina, or myasthenia gravis. We want to also know what the patient's drug history is. Why is that important? Some of these drugs have a drug-drug interaction, so we want to ensure that we have an accurate list of their drugs. We need the baseline vital signs. The pulse may increase after starting the treatment regimen. Determine your patient's knowledge as well. So many times meds are ordered for patients without them receiving the proper teaching concerning that new med. Another assessment to be made is urinary output as a baseline. This is because urinary retention may occur with continuous use of anticholinergics. What are we going to diagnose? They could have impaired physical mobility, impaired urinary elimination, and knowledge deficient. Planning. What is your goal? What's your goal for these patients? We want to know that when we start these medications and we do the teaching, the patient's taking the medications as directed, that we're seeing a decrease or an elimination of the extra movements. We want to intervene by monitoring their vital signs, their urine output, and bowel sounds. Increase pulse rate, urinary retention, and constipation are side effects of anticholinergics. Observe for involuntary movements. We want to, again, teach to avoid alcohol, cigarettes, caffeine, and aspirin to decrease the gastric acidity. Evaluation is our final stop on the nursing process train. How did the patient respond to the new meds? Are the symptoms resolved? Are they decreased? What about the side effects? Those are the things that we need to look at. Now let's talk about some dopaminergics. The carbidopa, levodopa, Sinemet. The action is converted to dopamine. It increases mobility for the patient. It does come with some side effects. I told you the first dopaminergic drug that we used it was kind of the standard for a long time was levodopa. It had to be given in extremely high doses because 99% of it was converted to dopamine before it reached the brain. This is why the alternative drug of carbidopa, levodopa was developed. The combination produced some advantages. More dopamine reaches the basal ganglia, and smaller doses of levodopa are required to achieve the desired effect. Of course, the side effects, it comes with those. I mean, there's not any med out there that doesn't have a side effect with it. Fatigue and insomnia, dry mouth, blurred vision, orthostatic hypotension, palpitation, dysrhythmias, urinary retention, nausea, vomiting, dyskinesia, psychosis, and severe depression. It does have drug-drug interactions. They can decrease the levodopa effect with anticholinergics, phenytoin, tricyclic antidepressants, MAO inhibitors, benzodiazepines, phenothiazines, and vitamin B6. So we need to be aware of that, and that's why it is important when we're doing an assessment on our patient, we are obtaining their complete drug history. Symmetrel is given PO. This is a dopamine agonist. It's also an antiviral drug for influenza A. I thought that was interesting to know. Action, it stimulates the dopamine receptors, taken alone or in combination with levodopa or an anticholinergic. It's used to treat for treatment of early Parkinson's as the drug tolerance develops. It does have improvement of symptoms. That's what we're looking for. That's what we hope to gain when we utilize this drug. Effective for rigidity and bradykinesia. It does not decrease the tremors effectively, though. Some of the other drugs in this category are bromocriptine, pramipexole. Sorry, I said that wrong the first time. Ropinirole. Those are just a few of the other drugs that are in this. Nursing interventions. We want to monitor for orthostatic hypotension with these patients taking that. Administer drug with low protein foods. Avoid vitamin B6, alcohol, and other depressants. We do not want the patient to abruptly discontinue this medication either. Warn of harmless brown discoloration of urine and sweat. Assess for suicidal tendencies. Assess their symptom status and on-off phenomenon. Monitor the blood cell counts, liver, and kidney function. Now we're going to move on to some Alzheimer's disease. It's probably one of the saddest neurological disorders, in my opinion. The patient slowly begins forgetting, knows they are forgetful, soon finds they are lost in their own world. They may not remember their loved ones. So I think about it as a disease where your loved one is slowly watching you sink into yourself and not able to do anything about it. You're there physically, but mentally that person is gone. It is an incurable dementia illness. It's chronic. It is progressive neurodegenerative condition. Um, they have marked cognitive dysfunction. Onset usually occurs between ages 45 and 65 years of age. They have neuritic plaques that form. Neurofibrillary tangles are in the neurons, and cholinergic neurotransmitter abnormality. I had a slide once in my neurological lecture that it showed the brain, an MRI of a brain, a normal healthy brain and one with Alzheimer's disease, and you could see it had shrunk so much. It was the most not miraculous. It was just it was a picture that when they say a picture is worth 1,000 words, that one spoke volumes. I wish I still had that picture. I would have thrown it into this presentation. Symptoms: the patient has memory loss, confusion, inability to communicate. They do begin to exhibit aggressive behavior. They have depression and psychosis, progression to loss of memory, logical thinking, and judgment, time disorientation. They have personality changes, hyperactivity, tendency to wander, inability to express oneself, and later hostility and paranoia. There are different stages to the disease process, stages 1 through 7, and you can review those on your table in your textbook 23-4. It's really, again, it's a sad disease to watch family members to go through. My stepmother's mother had Alzheimer's, and before she eventually died, she had stopped talking to my stepmother, and she was paranoid anytime that Sue came around. Um, she didn't know who she was. She didn't like her, and that was one of the hardest things for her to go through, was watching her mom. She just had to stop going around because every time she did, her mother would become very aggressive. So what are we going to do to treat these patients? It's incurable, but we do have medications that can treat the symptoms associated with it. Acetylcholinesterase inhibitors improve the symptoms. ACHE is an enzyme responsible for breaking down acetylcholine, and is also known as cholinesterase. Tacrine or Cognex, Donpezil or Aricept is the one that I know it by. Exelon and Rivastigmine. Those are all acetylcholinesterase inhibitors and cholinesterase inhibitors. They allow more acetylcholine in the neuron receptors. They increase the cognitive function of the patient. It's used in mild to moderate Alzheimer's. For mild to severe Alzheimer's, they're going to take Namenda. Okay, so now we're going to talk about Exelon. It's an ACHE inhibitor. It is prescribed to improve cognitive function for patients with mild to moderate Alzheimer's disease. Increases the amount of ACH at the cholinergic synapse. It slows the disease process, and there are few drug interactions than Donpezil or Tacrine. Exelon has side effects though: anorexia, nausea, vomiting, diarrhea, constipation, abdominal pain, GI bleeding and dizziness, depression, peripheral edema, dry mouth, dehydration, restless leg syndrome, and nystagmus. Some of the very adverse reactions that we might see with this medication are seizures, bradycardia, orthostatic hypotension, cataracts, myocardial infarction, and heart failure. So now let's look at the nursing process. If we were to have this take care of a patient beginning Exelon or in the middle of the therapy. Assessment-wise, we're going to look at their mental status and physical abilities. We're going to get a history and look for liver or renal disease dysfunction. Now, remember, this is prescribed for patients with mild to moderate Alzheimer's. So, assessing the patient's memory and judgment, we're hoping that once they've begun this regimen, that we can slow down the progression. We're not gonna take it away. We're only gonna take the symptoms away. Look for behavioral disturbances, difficulty in speech or motor function. What are we going to diagnose for this patient? Self-care deficits, bathing, feeding, toileting, chronic confusion, interrupted family processes. Those are just to name a few. Planning, improvement of symptoms, ability to perform self-care. How are we going to intervene for this patient? We're going to look for interventions that maintain the consistency. We need a regular schedule in this patient's life, which would mean that we would have to assess the family structure as well. We might have to assist with ambulation, monitor the patient for side effects, and monitor their vital signs. We want to explain to the patient, and particularly the family, the purpose for the prescribed med, clarify the time for drug dosing, and schedule for increasing drug dosing to family member responsible for their medications. Teach the family member about safety techniques, such as removing obstacles from the patient's path so the patient can avoid injury. There's also support groups for family members, and that we want to teach the side effects that we need to watch for with this medication as well. Myasthenia gravis. It is an autoimmune disease resulting from a loss of acetylcholine. Antibodies attached to the ACH receptor sites, obstructing the binding of acetylcholine and eventually destroying receptor sites. When the acetylcholine receptor sites are reduced, the molecules are prevented from binding to receptors and stimulating normal neuromuscular transmission. This results in ineffective muscle contraction and muscle weakness. Characteristically, they're going to have muscular weakness, fatigue, respiratory muscle paralysis, ptosis, difficulty chewing, and swallowing. Okay, so we want to look at acetylcholinesterase inhibitors or cholinesterase inhibitors. Neostigmine is a short-acting one. Tensilon is an ultra short-acting for diagnosing. Mestanin is an intermediate acting, and Metolase is a long-acting. Their action is transmission of the neuromuscular impulses by preventing destruction of ACH. We're using it to control and treat the symptoms that are associated with MG. If a patient is not responding to acetylcholinesterase inhibitors, we're going to start them on dosing of prednisone. We're going to do a plasma exchange. These patients are probably going to receive some IVIG, intravenous immunoglobulin, or immunosuppressive drugs like Imuran. ACHE inhibitors, overdosing and underdosing, be aware. And this is not just important for this part of pharmacology. This is important. You're going to see this on HESI, and I know that I've seen this in the NCLEX test plan, the overdosing and underdosing for myasthenia gravis. It is similar symptoms, so you have to pay particular attention to what the question is asking you. Muscle weakness, dyspnea, dysphagia, abdominal cramping, drooling, increased tearing, sweating, and bradycardia. A crisis, myasthenia crisis, the patient is underdosed, or they might not have been given their medication at the prescribed time. It has to be given at the exact same time each day. Or a cholinergic crisis, and that's when they're overdosed. We must make sure that we give those medications on time to avoid any crises. In a crisis, their patient is going to suffer from severe muscle weakness. It may involve the diaphragm and the intercostal muscles. Triggers: inadequate dosing, infection, emotional stress, menses or pregnancy, surgery, trauma, hypokalemia or alcohol intake, medication interactions. It improves after tensilon and prostigmine. If untreated, myasthenia gravis crisis can cause death from paralysis of the respiratory muscles. It may occur 3 to 4 hours after taking certain medications. Especially we're looking at calcium channel blockers, psychotropics. Those are a couple of the ones that might cause a crisis. A cholinergic crisis usually occurs within 30 to 60 minutes after taking the anticholinergic medication. The patient presents with severe muscle weakness, possible respiratory paralysis and arrest, abnormal pupil constriction, excessive salivation, pallor, sweating, vertigo, GI distress, bradycardia, fasciculations. It does worsen after administering tensilon, and the main trigger for a cholinergic crisis is overdosing. Side effects of ACTH inhibitors: they have GI disturbances, nausea, vomiting, diarrhea, abdominal cramps, increased salivation, tearing, miosis, constriction of the pupil of the eye, blurred vision, bradycardia, hypotension. Nursing process for ACTH inhibitors. Assessment-wise, as per usual, and I stress it all the time, how we need thorough health histories and drug histories on these patients. We don't want any drug-drug interactions. No muscle relaxants. Avoid atropine-like drugs. Baseline vital signs need to be obtained, as well as a list of signs and symptoms the patient is experiencing currently. Make note of any breathing or swallowing difficulties. What are we going to diagnose with these patients? These include ineffective breathing pattern, activity intolerance, anxiety, and knowledge deficit. The goal for this patient is to eliminate or reduce the problems associated with the MG within 2 to 3 days following the beginning of the med. Interventions include your teaching, take as prescribed to avoid recurrence of symptoms, encourage the patient to have on their person some type of medical identification, alerting others to their condition. Also, we want to make sure to administer doses on time. Take the drug before meals if possible. Monitor the drug effectiveness. We want to evaluate the effectiveness of the drug therapy, ensure absence of respiratory distress, and make sure the patient has been using this drug correctly at the right times. Multiple sclerosis is our next disease process that we're going to look at, and the meds associated with it. It is an autoimmune disorder. It attacks the myelin sheath of nerve fibers in the brain and spinal cord. It does cause lesions and plaques. Characteristically, these patients have remissions and exacerbations. They're weak. They have spasticity in the extremities and diplopia. There is really not any specific diagnostic test for these patients. There is a McDonald criteria that was used to aid in diagnosis. Um, and I'll be honest with you, I didn't look further. Your text and your pharmacology text does not address the McDonald criteria, and I didn't look further because we're talking about pharmacology, and I wanted to get right to your medications. Basically, laboratory tests may suggest MS that include elevated immunoglobulin in the cerebrospinal fluid, increased IgG and albumin ratio, and multiple lesions observable through MRI. The treatment, there are 3 phases of MS, and there's treatments associated with each phase. There's an acute attack. The patient exhibits fatigue, motor weakness, and optic neuritis. The treatment of choice at this point is glucocorticoids, corticotropin, and be administered 80 to 120 units IM every day for 2 to 3 weeks. The remission and exacerbation phase, the patient exhibits recurrence of clinical MS symptoms with spasticity. So the biologic immune response modifiers are administered. These are discussed in another chapter. I'm not going to go into them in depth in here. Interferon B is administered, which helps to reduce the spasticity and improve muscle movement. And then there is the chronic progressive phase. The patient has progressive MS symptoms and often confined to a wheelchair. At this time, they will receive Cytoxan, which is an immunosuppressant. Now we're going to talk about some skeletal muscle relaxants. Um, for spasticity, we probably will give these patients some baclofen, some tizanidine or Xanaflex. I like to say Xanaflex better. It is essentially acting, and a direct acting is dantrium. Muscle relaxants are administered to help to alleviate the muscle spasms, and it depends on the drug. They're either central or direct, central or direct acting. Central acting are used for cases of spasticity to suppress the hyperactive reflex and for muscle spasms that do not respond to anti-inflammatory agents, physical therapy, or other forms of therapy. There's other muscle relaxants. These are some more centrally acting ones. Soma, Paraffin Forte, Robaxin, Scalaxin, or Norflex. Soma aids in relaxing skeletal muscles, has a CNS depressant effect. It is for short-term use, usually around 2 to 3 weeks, and the patient should avoid alcohol when they are taking this med. The Paraffin is used for acute or severe muscle spasms. The patient should take with food to avoid GI upset. Robaxin, acute muscle spasm use. Urine may be green, brown, or black. I thought that was pretty interesting. That could be a little startling for a patient to see. Scalaxin is used for acute and painful muscle spasticity. And Norflex, it is important to note that it can be toxic with a mild overdose. Okay, these are our depolarizing muscle relaxants. These are used in adjunct to anesthesia. So when you're working in surgery, this is where you probably will see most of these. Okay, so now we're going to talk about a skeletal muscle relaxant, Flexeril, a very, very common one that's administered. Of course, its action is to relax the skeletal muscles, alleviates muscle spasm associated with acute painful musculoskeletal conditions. It's so very common. It's used for various treatments where muscle relaxation is needed. It is well absorbed in the GI tract, and it has a half-life that's pretty moderate. It is metabolized in the liver and it's excreted in the urine. Side effects from it though, anticholinergic effects, drowsiness, dizziness, headache, fever, abdominal pain, vomiting, diarrhea, and flatulence, as well as erectile dysfunction. So we're going to look at the nursing process for Flexeril in particular. We want to get a medical history for this patient because this med is contraindicated in patients with cardiovascular disorders, hyperthyroidism, or hepatic impairment, and also if the current is currently taking MAOIs. We need to get baseline vital signs, assess whether the muscle spasms being reported are from an acute or chronic condition. What is the patient drug history? It's actually contraindicated in patients with narrow angle glaucoma or myasthenia gravis. So this is why it's very important that we get that history. Diagnosis, we want to diagnose with impaired physical mobility or activity intolerance. The goal is to achieve freedom of muscular pain within 1 week. Nursing interventions associated with it, we want to instruct the patient to take the medication with food, monitor their liver function, check vital signs, Advise the patient not to drive while taking the medication. Inform the patient that most centrally acting muscle relaxants are prescribed for no longer than 3 weeks. Teach a patient not to stop this medication abruptly, discontinue over 1 week to avoid rebound spasms, and have the patient to also avoid alcohol and other depressants while taking the medication. We also want to teach them about the side effects that are associated with it. The nausea, the vomiting, the dizziness, fainting. The dizziness and fainting are likely caused by orthostatic hypotension, so we want to teach them to rise slowly, and headache and diplopia. This is the end of your Neuro Med lecture for pharmacology. I hope that you find the information presented as useful for future testing purposes. Thank you.